Hello, my name is Dr. Rosario Bartolomeo. I'm an internal medicine resident second year at the Advocate Christ Medical Center located in Oak Lawn, Illinois. Here we're presenting a case on Mycoplasma hominis vascular graft infections. So Mycoplasma hominis is considered a commensal organism of the human genital tract. It was traditionally implicated in genital urinary, postpartum, and most commonly neonatal infections. However, it's becoming increasingly identified as a pathogen found in surgical site infections, even in those that are immunocompetent. So here we're presenting the case of a 58-year-old female with a past medical history significant for essential hypertension, hyperlipidemia, and coronary artery disease. She also has quite prominent peripheral vascular disease for which she had received a left femoral arterial stent that unfortunately was complicated by pseudoaneurysm. The pseudoaneurysm was repaired, and she then, on July 20th, had received a left femoral artery to right femoral artery vascular graft. On August 3rd, the patient presented to an outside hospital with complaints of fever and a non-healing left groin wound. She was diagnosed with methicillin-sensitive Staphylococcus aureus and Prevotella buccali positive soft tissue infection, and unfortunately, Staphylococcus aureus bacteremia. She was treated with 2 weeks of metronidazole and plans for 6 weeks of oxycillin. On August 18th, the patient returned to that same hospital with complaints of persistent left groin bleeding and skin changes. On August 25th, the patient was transferred to our facility for vascular surgery evaluation and concern for a vascular graft infection. On admission, her vitals were stable. She was afebrile, her blood pressure was normal, her heart rate was normal rate, and she was saturating 99% on room air. Labs were significant for a C-reactive protein elevated at 4.6 milligrams per deciliter. Her CBC did not show any evidence of a leukocytosis or a neutrophilia. Physical exam was significant for a left groin wound with bloody drainage and an open fistula over the left groin wound. The left groin was tender with induration along the entirety of the graft with extension to her mons pubis. Imaging was performed, which included a computed tomography and angiography of the abdomen, pelvis, and her lower extremities. This imaging demonstrated progression of a left groin collection with pockets of gas without any definite contrast extravasation near the femoral to femoral graft anastomoses. So with this information in mind, it was suspected this could very well be a Samson grade 3 infection. Her antibiotics were escalated to cefepime and vancomycin, and she ultimately underwent surgical debridement. The operative findings were significant for inflammation and phlegmon on the left side of the bypass, with quite significant anastomotic bleeding, for which the patient actually required a unit of blood during the surgery. Her bypass was excised and replaced with a saphenous vein patch and a sartorius muscle flap. Her operative cultures and blood cultures were obtained and sent to laboratory. Her operative cultures initially did not grow anything, but ultimately needed to be re-incubated. The reincubation resulted in pinpoint colonies that did not gram stain. The sample was sent for polymerase chain reaction testing, which returned positive for Mycoplasma hominis. So the patient was transitioned to doxycycline, and she was successfully treated after 6 weeks of doxycycline and 6 weeks of oxycillin for her Mycoplasma hominis graft infection and still present MSSA Samson grade 5 extracavitary vascular graft infection. On the left here, we have a picture of these small pinpoint colonies. And although usually considered a commensal organism, Mycoplasma hominis has been described to cause these invasive infections, including vascular graft infections, sternotomy infections, transplant infections, even in those that are immunocompetent. It's thought that disruption of the mucosa or immunocompromise can result in pathogenic behavior of this organism. These infections are often culture negative on routine testing, so prolonged incubation can yield these small pinpoint colonies as we see here. Again, they do not gram stain. So our case highlights the importance of maintaining a really high degree of suspicion for these atypical pathogens like Mycoplasma, and especially in those with individuals with a very prolonged course without any improvement of their wounds. It also raises awareness for the organism itself that is increasingly identified as a pathogen. Thank you very much.